This is the fifth part of the ECG analysis pediatric patients from Dr. N.S. Mani. And previous session we stopped with the bundle branch block. I'm resuming from that part. A complete right bundle branch block may be congenital or may be acquired after surgery for congenital heart disease, especially when a right ventriculotomy has been performed, as in repair of tetralogy of Fallot. Congenital left bundle branch block is rare. This pattern is occasionally seen with cardiomyopathy. A bundle branch block pattern may be indicative of a bypass tract associated with one of the pre-excitation syndromes like WPW syndrome. The PR interval and the QT intervals. The duration of the PR interval shortens with the increasing heart rate. Thus, the assessment of this interval should be based on age and rate-corrected nomograms. A long PR interval is diagnostic of first degree heart block, the cause of which may be congenital, postoperative, inflammatory like myocarditis, pericarditis, rheumatic fever, or drugs, pharmacologic drugs like digitalis. Duration of the QT interval varies with the cardiac rate. A corrected QT interval, that is called QTC, can be calculated by dividing the measured QT interval by the square root of the preceding R interval. Normal QTC should be less than 0.45 seconds. It is often lengthened with hypokalemia and hypocalcemia. In the case of hypokalemia, a U wave may be noted at the end of the T wave. There are a number of medications that can also lengthen the QT interval. A congenitally prolonged QT interval may also be seen in children with one of the long QT syndromes. These patients are at risk for ventricular arrhythmias, including a form of ventricular tachycardia known as torsades de pointis and sudden death. I am showing you the ECG of hypokalemia, that is serum potassium low, 2.7 milliequivalent per liter. Serum calcium was 4.80 milliequivalent at the time of tracing. Note the prolongation of electrical systole as evidenced by a wide TU wave as well as deep depression of the ST segment in the lead V4R, V1 and V6, which I have shown with red arrows. And in this panel I am showing you the prolonged QT interval in a patient with long QT syndrome, and the two arrows are approximately the beginning of Q wave, beginning of Q wave to the end of the T wave. ST segment and T wave abnormality. A slight elevation of this T segment may occur in normal teenagers and is attributed to early repolarization of the heart. In pericarditis, irritation of the epicardium may cause elevation of this T segment followed by abnormal T wave inversion as healing progresses. Administration of digitalis is sometimes associated with the sagging of this T segment and abnormal inversion of the T wave. Depression of the ST segment may also occur in any condition that produces myocardial damage or ischemia, including severe anemia, carbon monoxide poisoning, aberrant origin of the left coronary artery from the pulmonary artery, glycogen storage disease of the heart, myocardial tumors, and mucopolysaccharidosis. An aberrant origin of the left coronary artery from the pulmonary artery may lead to changes indistinguishable from those of acute myocardial infarction in adult. Similar changes may occur in patients with other rare abnormalities of the coronary artery and in those with cardiomyopathy, even in the presence of normal coronary arteries. These patterns are often misread in young infants because of the unfamiliarity of pediatricians with this infarct pattern, and thus a high index of suspicion must be maintained in infants with dilated cardiomyopathy or with symptoms compatible with coronary ischemia, like inconsolable crying. T-wave inversion may occur in myocarditis and pericarditis, or it may be a sign of either right or left ventricular hypertrophy and strain. Hypothyroidism may produce flat or inverted T-wave in association with a generalized low voltage. In hyperkalemia, the T-wave are commonly of high voltage and are tent-shaped. In this ECG, I am showing you a case of hyperkalemia where the serum potassium was 6.5 millikilon per liter and the serum calcium was 5.1 millikilon per liter at the time of recording of ECG. Note the tall tent-shaped T wave, especially in lead 1, 2 and V6. And also in AVF. These are shown as by the arrow marks. Cardiac axis is the next step in ECG analysis. Something about adult cardiac axis I am saying. The cardiac axis refers to the mean direction of the wave of ventricular depolarisation in vertical plane. In the vertical plane measured from a zero reference point. The zero reference point looks at the heart from the same viewpoint as lead 1. An axis lying above this line is given a negative number, and an axis lying below this line is given a positive number. Theoretically, the cardiac axis may lie anywhere between plus 180 and minus 180. The normal range of the cardiac axis is between minus 30 and plus 90 degree. An axis lying beyond this minus 30 is called left axis deviation, and whereas an axis more than plus 90 degrees is called right axis deviation. And the same law appears applicable in children also, but only thing is that according to age the axis may be physiologically normal. And conditions for which determination of the axis is especially helpful in diagnosis. One is conduction defect, for example left anterior hemiblock. Then ventricular enlargement, for example right ventricular hypertrophy. Then broad complex tachycardia, for example visceral axis suggestive of ventricular origin of the impulse. Then congenital heart disease, for example ASD, can be diagnosed. Then pre-excitation syndrome like WPW syndrome, and also in pulmonary embolism. I will show you examples in the form of ECGs, real-time ECGs, so that you will understand these concepts in the coming sessions. So please watch the YouTube content. Now I am showing you a simple method which is used to calculate the cardiac axis. Please look at your right side where I am showing you the 3-column table. One is show the lead, the number of lead is equal to number of the letter L, and fill the remainder with the letters RA or A. This is an easy method of remembering which limb is carrying the positive pole of the ECG, bipolar lead. For example, in lead 1 there is only one L, the remainder is filled with A and RA. That means positive pole left atrium, left upper arm, and negative pole in the right arm. They lead to two letters L and the remainder is RA, so it means left lower limb is the positive pole and the right arm is the negative pole. And letter number 3, that is third lead, means 3L, so there are 2L on the left side and 1L on the right side, and there is a that means the positive pole is left lower limb and negative pole is left arm. So that way you can easily remember the positive and negative lead in 1, 2, 3. Actually the AVR, AVL and AVF are very easy to remember. The letter R means positive pole is in right arm, letter L means left arm, and F means feet or left feet or left lower limb. Now will you calculate the cardiac axis. Lead 1 normal axis will show positive, lead 2 will show positive, and lead 3 positive or negative deflection. Whereas in right axis deviation, lead 1 will be negative, lead 2 may be positive or negative, and lead 3 will be positive. And even left axis deviation, lead 1 will be positive, lead 2 will be negative, and lead 3 will be negative. The direction of current flow is towards the lead with a positive deflection and away from the lead with a negative deflection, and at 90 degree to a lead with a equiphasic QRS complex. So you choose the limb lead closest to being by equiphasic, and the axis lies 90 degree to this right or left of this lead. With reference to the hexaxial diagram, inspect the QRS complex in the lead adjacent to the equiphasic lead. If the lead to the left side is positive, then the axis is 90 degree to the equiphasic lead towards the left. If the lead to the right side is positive, then the axis is 90 degree to the equiphasic lead towards the right side. Easy to remember is thumb rule. You keep your left thumb on lead 1 and right thumb on AVF. Which thumb is positive means that axis. So if the left thumb is positive, that is left axis deviation, which is placed on lead 1. If it is the thumb is placed on, if the right thumb is showing positive, which is placed on AVF, if it is positive, that means it is right axis deviation. So that is the session on the ECG tutorial. Hope that you like that session, and that is from Dr. N.S. Mani in the site www.youtube.com/ACPGMet. Please visit the channel. Thank you.